Hi, this is Natalia Murinova, and I'm the Medical Director and Clinical Associate Professor at the University of Washington. I head the headache clinic, but also work in patient neurology. So welcome. If you're awake, thank you for being with me, or if you're watching it later, enjoy. So these are the providers of the headache clinic and our team at the members of the headache clinic. So why are we talking about headaches? So first of all, I was told that you guys like questions, so I have a few questions throughout the presentation, and we'll start with, what percentage of people suffer from headaches? What headaches are the most common? Are there tension type headaches or migraines? And what are the most commonly encountered headaches by medical providers? Ready for the answers? Turns out more than 90% of people suffer from headaches. Tension type headaches is the most common. More than 86% women in their lifetime will have tension type headache. Men, 63%. So yes, hormones do matter, but they're not everything. However, the most commonly encountered headache seen by physicians is migraine. Migraine is about 25% of population, and that's the number one headache that patients come from, both to their clinic, but also to the emergency room. Now, how is chronic headache defined? What does it really mean when we say chronic? Is it the number of the days? Is it every day? Is it since you were 5 years old? So that's our question. And current definition is actually very simple. All you need is calendar. And if you have more than 15 days per month of any headaches, it's chronic headache. So again, more than 15 days per month. It's very arbitrary. We start worrying when people start having more than 6 days per month, or even if they have one headache and they can't function. So how common are chronic migraines? Another question. Well, it turns out that 4.1% of general population definitely has chronic migraine. We think it's much more than that. Currently in our headache population, we have done a study of more than 1,000 patients coming to us, and more than 70% of patients presenting to us have chronic migraine. In the US, the estimate is anywhere from 13 to 30 million people. Current estimate that more than 60 million people in the US have migraines. As we speak, half the world has tension type headache. So what makes it easier for us to diagnose chronic headaches? What is the easiest thing you can do? Well, you can start a headache diary. So there's many trackers now available in use. We're working at the University of Washington developing our own app, but iHeadache, Migraine Buddy are some of the popular ones. There are many popular apps, and majority of the patients, if they fill it in, they can then email you the final score. So you'll know exactly how many headache days. Not only that, it will differentiate for you whether it's migraine, tension type headache, or other type of headache. Now, we have a headache survey at the University of Washington called REDCap, and all of our patients fill it in. That's where we have all our data, and we'll share those with you throughout the year. Now, big question that always comes up to me is, Natalia, should I worry about my patient with headaches? They've had headaches for 20 years. Should I worry or not? And we have something that is called red flags. So what are some of the red flags? If you have first or worst headaches, so if you've never ever had a headache, you have a headache, that's really worrisome. Thunderclap, if the headache is present within seconds and the intensity is 10 out of 10. Associated fever and meningismus. We were taught that it's a big issue, obviously, for meningitis, but the current thinking was that only in patients who are immunosuppressed or have cancers, other immunosuppression, such as HIV, could they get fungal meningitis. Right now I'm inpatient at the University of Washington, and we have a healthy gentleman who has cryptococcal meningitis. So unfortunately, meningitis can happen in healthy people, and some of the ID people think that it has to do with your genetics. Papilledema, if patients have reduced loss of consciousness, acute glaucoma, these are emergent red flags. So if patients report to you first and worst, thunderclap, fast onset, fever, they have papilledema, loss of vision, reduced loss of consciousness, acute glaucoma, you need to send them to the emergency room. So, now, what imaging is the most useful for your patients with headaches? We always say, discuss with your friends. Maybe you're on your own, but CAT scan in the emergency room because we're trying to rule out head bleed. That's what you see in the picture. On the other hand, typically MRI is the best. Now, when do we add MRA? When do we add MRB? So MRA is anytime you're suspecting aneurysms or any vessel changes. When would you suspect that? If you have a young person with first ever headache, exertional headaches, those are the slides. So the next slide I have is there are more than 2 to 3 million people in the emergency room every year who are coming with a primary complaint of headache. Majority of them have chronic migraines or migraines. About 14% of visit will have neuroimaging, and if you look at the bottom of the slide, it shows you that only 5% of people will be found to have actually a pathologic diagnosis. So majority of the people who come to the emergency room do not have something ominous, but it is our role to make sure they're safe, and then once they're safe, come up with effective treatment. If you can see on the slide next to it is lumbar puncture. So again, about 2% of patients coming to the ED will have lumbar puncture. About approximately 10-11% will have abnormal lumbar puncture. So this is where it becomes sometimes distressing for physicians, because you have a patient who comes with very severe headache, you proceed with neuroimaging and lumbar puncture, and both of those are normal, as you can see from these slides. More than 90% of the patients coming to the ED have normal exams. So it means out of the 2 million people, it's more than 1,800,000 patients who come to the ED every year who have completely normal imaging, normal lumbar puncture. So what do you do next? So the key is the diagnosis. If you don't know what the diagnosis is, you can come up with a treatment. And International Headache Society criteria is what we currently use. If you Google IHS criteria and migraine, you'll get to the International Headache Society criteria, and that's what I use with my patients to try to come up with their correct diagnosis and show them what the criteria are. So this is the International Headache Society classification. So it's divided into primary headaches and secondary headaches. Secondary headaches just means that something else is causing the headache, such as brain tumor or sinusitis or trauma. Even medication overuse is considered secondary. Primary headaches, the main category that you're going to see are going to be migraines, but you could also see patients with tension type headaches, cluster headaches, and other primary headaches. Now, migraine is currently divided into migraine without aura, migraine with aura, childhood syndrome, so this is the patients who have commonly cyclic vomiting syndrome, retinal migraine. Complications of migraine, if you open that, that's considered chronic migraine, more than 15 days a month. Probable migraine is if you're missing one criteria. Let's say you have someone who comes to you, has very severe disabling headaches that have been more than 5 days per month. However, they do not have associated nausea, light or sound sensitivity. That's probable migraine. Now, if you open these, you would see that migraine without aura, and we'll go to that in a bit, is the most common diagnosis. From migraines, 80% of migraine patients do not have aura. So I have often patients asking me, like, I've never had an aura, I never had visual symptoms. Is it a migraine? Yes, it is migraine if it meets otherwise criteria. So I'm going to go to the next slide. So again, the primary headache are migraine with and without aura, tension type headache, trigeminal autonomic cephalalgia. That's where cluster belongs, that's where hemicrania belongs, and other primary headaches. So there are headaches like hypnic headache, and nummular headache, and other headaches. There's more than 200 different kinds of headaches. The good news is, most of you, if you put all your bets into migraine, are going to be more likely correct than not. Also, commonly patients who have migraines have associated tension type headaches. That's a very, very common type of headache. So commonly combined, you'll see the first two categories. Next slide. So how do you know someone has a migraine? So they have to have at least 5 headaches in their lifetime. You don't want to diagnose someone with first ever headache with a migraine. If people have first worst, remember, that's a red flag. Those are the patients you need to evaluate for other type of headache, specifically secondary headache. So classically, migraine is one-sided severe pain. in children, it's usually bilateral. Also, it's only one-sided in 60% of people. So if someone comes with bilateral headache, does not exclude a migraine, but if they have one-sided pain, it's more likely that they have a migraine. Now, classically, the symptoms that are associated with migraine are light sensitivity, sound sensitivity. It's almost as the dial, kind of like we have the old-fashioned dials on the radios, is turned up. So all the environment is more on. So light, sound, smells, they perceive everything. Patients will tell me that they smell anything in the room. They perceive the lights, the fluorescent lights bother them. They're very sound sensitive. And this is upturned when they have a migraine. Now, what is the main question, though, that makes the diagnosis of migraine more likely or not? And how do we decide? So, again, coming to the migraine. So, you have to have at least 5 headaches lasting from 4 to 72 hours. So, if you have headaches that are under an hour without treatment, that's not a migraine. And if they last more than 72 hours, you get into what is called status migraine. Now, technically, people who have migraines will have unilateral pain. It's usually described as throbbing or pulsating, or worsened with movement. It's moderate to severe. You have to have at least 2 of these. So most people will say they have moderate to severe pain where they can move, and at least one symptom such as nausea or vomiting, light or sound sensitivity. If you're missing one of these, then it's probable migraine. So what is the question that establishes the correct diagnosis? So if you had only one question to ask, what would you ask? And the question would be, what do you prefer to do? So if you prefer to lay down, it's a migraine. If you prefer to get up and bang your head into the wall, more likely cluster headache. If you do not care what you do during the headache, it's usually tension type headache. So again, the preference for patients who have migraines is to lay down, typically in a dark room with no noise, with no smells. That's what they prefer. So what is about tension type headache, and how does it contrast with migraine? So tension type headache, you have to have at least 10 episodes in your lifetime. The headaches can last anywhere from 30 minutes to 7 days or longer. Technically, they're usually bilateral. It's usually pressing, tightening. It could be mild to moderate. It's usually not severe. It's not aggravated by routine physical activity such as walking and climbing. And patients do not have nausea or vomiting. They sometimes can have mild light sensitivity or sound sensitivity, but it's not as extreme as migraine. Again, tension type headache very commonly occur with patients who have migraines, mostly if they get into chronic migraines. Now, our next patient presentation. So we have a 24-year-old actor. I'm sure you recognize him since you watch TV. And he's been having 90 minutes of disabling retroorbital pain without visual changes. Headaches occur every night. So again, young person, 90 minutes, disabling retroorbital pain, no visual changes. And what are you observing there's of clinical significance in this picture? So the red area is a pain area. You see that the eye is droopy. You can see that the pupil is slightly smaller and there's tearing. So these are called autonomic symptoms. So unilateral tears, ptosis. So it's usually sympathetic dysfunction, parasympathetic overactivation. Patients can also have stuffy nose. They can feel restless. If they have these autonomic symptoms, what is happening? So this is from Dr. Goldsby's slide. So along with activation of the thalamus that activates trigeminal nerves that cause pain, you have activation of the parasympathetic and sympathetic system, so pterigopalatin ganglion, PPG, where all the different fibers intersect. So these patients don't have only activation of their trigeminal system, but also of their autonomic nervous system. And what does that mean? Usually cluster or hemicrania, one of those stack headaches. So what are the diagnostic criteria of cluster? So you have to, again, have at least 5 attacks in a lifetime. So if someone has first ever attack with cluster, you need to make sure they don't have a brain tumor. It's very, very common to have brain tumors in certain areas, such as hypothalamus, that present with cluster-like symptoms. So again, severe or very severe unilateral, orbital, supraorbital, and or temporal pain that lasts usually from 15 to 180 minutes if untreated. the headaches have at least one autonomic symptom, most commonly the same side conjunctival injection redness, or tearing on the same side, or nasal congestion on the same side, or rhinorrhea on the same side, or ipsilateral eyelid swelling. They can also have facial sweating. They can have ipsilateral, the same side, miosis, so pupil is small compared to the other pupil, and ptosis, eyelid droop. They feel restless and agitated. So if you have a patient who has this, more likely than not, it's a cluster headache. Now, if it's a female patient, it might not be cluster, and I'm going to talk about it in a little bit. So again, autonomic symptoms. These patients often have suicidal ideation. Up to 55% of them have reported suicidal thoughts. So this is a very severe headache. Many of these patients have self-injurious behavior during the attack. They literally do bang their heads into the walls. It's so disabling. And 2% of them have actually tried to commit suicide. So if you see a patient who has one-sided, very severe pain with autonomic symptoms, that's a referral to the headache clinic, and you can call me or email me because we'll need to see them urgently. This is a very disabling headache. Now, there's diagnostic delays. I have seen many patients in my clinic where the delay has been 10 years or longer. On average, it's delayed 5 to 10 years. And if you say, why is that? Well, women can have cluster headaches. It used to be thought that only men have it. It is rare in general population. So I told you the migraines are up to 25% of U.S. population. Cluster is 0.5% of population. There is also delay because some patients can have both migraines and clusters. Also, some patients with clusters can have some of the migraine features, such as light or sound sensitivity. However, they'll have overarching one-sided tearing, rhinorrhea, nasal congestion. You can see more than 90% of patients will have that. Now, cluster. Why is cluster called cluster? Because it clusters during your calendar during the months of the year, so much more you can see in March and April. So I have a sigh of relief because now we're in July. You can still see them, but not as much. And then the other area where they increase again, where I become more busy, is September and October. So they usually last 4 to 8 weeks, and the attacks recur during this period, and they cluster. In some people, only one attack per year, and some 2 attacks a year. Unfortunately, a very small percentage of patients gets into chronic cluster, and then it continues throughout the year. Time of the day, initially, you can see most of the attacks are between 10 p.m. and 4 a.m. Some people call it kind of the magic hour at 2 a.m. A lot of patients will wake up at 2 or 3 with having these debilitating attacks. Now, these headaches are often confused with paroxysmal hemicrania or hemicrania continua. I've seen 2 patients last week in the clinic who had diagnosis of migraine, and then someone thought maybe they could have cluster. Well, it turned out that they have hemicrania. How did I know that? The attacks were really short. They were less than 20 minutes. And they were both women. I started them on indomethacin, and in one woman after 20 years, and the other woman after 10 years, the headaches are gone. So good news, if you have the correct diagnosis, you have the correct treatment, you can get treatment and you can improve. Now, how do we treat clusters? So acute treatment is oxygen. You can use triptan injections. You don't want to use pills. It's too short. You can use DHE45 injections for acute treatment. For prophylactic treatment, it's usually verapamil. Usually you start 60 milligrams up to 3 times a day. You can do 80 milligrams a day. And I have many patients who I've seen over the years who know when their attacks are going to come. They know, always in March I have an attack, so we start the treatment actually the month before. I've had some patients with chronic cluster where we just kept them indefinitely on verapamil. And then we can add prednisone. Usually we add 20 milligrams a day for 4 weeks, and then 10 milligrams for another 4 weeks. So hemicrania treatment is indomethacin. It turns out that melatonin is very similar structurally to indomethacin, and you can use melatonin instead. So you could use melatonin 5 to 10 milligrams at night instead of the indomethacin. So again, coming to chronic daily headaches. So I think after this, you're going to know that if a patient has more than 15 headache days per month, they have chronic headaches. Doesn't mean that you should not worry if they have 14 or 11. Anytime patients have over 6 days a month, we worry because acute medications can be making it worse. Anytime people take Advil more than 10 days per month, and they're prone to migraines, they can develop daily headaches. So I commonly see patients who had trauma, they had pre-existing migraines, they start treating their post-traumatic headaches with Advil every day, and they develop daily headaches. And if you can discontinue the Advil and replace it with other prophylactic medications, many of these patients can significantly improve. So what medications are not great if you are a headache sufferer? So thanks, mom and dad. If you have your genetics for migraines, what are the medications you should not be taking more than a certain amount? Opioids. You should not be taking more than 6 days of opioids per month forever for whatever condition. Combination analgesics. The most popular in the US are Excedrin. If you take Excedrin more than 6 days a month and you're prone to migraines, you will get worse. Caffeine. So what is an okay dose of coffee? So I'm here in Seattle. Starbucks is in Seattle, so we're not anti-coffee. Everybody loves coffee here. So probably 1 cup of coffee a day could be great. If you're drinking 8 cups of coffee, maybe not so great if you're having headaches. Barbiturate-containing medications, so butalbital, Fioricet, Fiorinal. I have many patients who are coming to me with medication overuse from these medications. Ergotamines, even triptans that are designed to treat headaches. If they're used more frequently than 8 days per month, on average, they will contribute to significant worsening of headaches. So we actually limit them in our headache clinic to 6 days per month to be on the kind of safe margin, and then we add prophylactic medications. There are many other medications that can cause transformation. So what do we then do at the headache clinic? So we believe in what we call multimodal treatment, and so it involves education regarding the medications that can cause you more harm if you're a headache sufferer. We talk extensively about prophylactic treatment. I'll talk about it in a little bit. But it turns out that relaxation, exercise, nutrition play as big role as not taking medications. So there are studies that have been done. There's in Scandinavia, Dr. Warki proceeded with a study where she compared relaxation 1 hour a day to exercise 1 hour a day to taking daily prophylactic medications, the pyramid, for 3 months. And 3 months later, guess what? Who had the best results? Well, it turned out that everybody had the same results. So if you do relaxation an hour a day, or exercise an hour a day, or you take daily prophylactic medication, you can improve about 30%. If you want to improve more than that, you need to combine these approaches, and that's what we suggest. That just exercise. I have many patients who said, oh, I've tried exercise, I've tried diet, I've tried this, but they did it sequentially. They didn't do it all together. So we need to do it together. And that's a multimodal approach. So what is the standard of care for preventive medications? So any patient who has more than 4 days of migraines a month, any of your patients who have the chronic headaches, any headaches, should be on prophylactic therapy. What prophylactic therapy can you offer? So it comes to old medications such as propranolol, topiramate, nortriptyline, but there are new medications such as Botox or SPG blocks that can be done as well. Examples of preventive medications, so you could do nortriptyline. Technically, what we use is something called flexible schedule dosing, and what it means is that you don't just give the patient a regimen where you say, okay, you have to start 10 milligrams, and then next week it's 20, next week it's 30. You say, this is how usually we increase the dose, but only you know if you have side effects or not. If you're very sensitive to medications, and let's say you give them propranolol, maybe start 2.5 milligrams and see how do you feel. If you feel fine, see, can you tolerate 5 milligrams or 10 milligrams? If you cannot, stay on the lowest dose of the medication that is not causing you side effects, and then wait for 2 or 3 months, see how you feel. If you feel they're severe, you could always add another medication. The most popular by far in the headache clinics is Topamax, topiramate. Why is that? Because most young women do not want to gain weight. The only medication that we have for weight loss is Topamax. It's also nicknamed on the websites as supermodel drug because it causes weight loss. So most of the young women, when I mentioned weight loss, they said, yeah, sign me up, I want Topamax. If they have very severe anxiety, sometimes we have to combine it with propranolol. It's a beta blocker that blocks the adrenaline binding. If people have very severe problems with sleep, sometimes you can add nortriptyline to Topamax. Sometimes you can add all three. The main guidance is using very small doses. So what are the doses of Topamax that we usually use in the clinic? Usually not more than 100 milligrams a day. Some young women prefer to stay on even lower doses, like 25 or 50 milligrams. Again, it's flexible dosing. If they feel good and they tolerate it, that's the key. Now, what about acute therapy? So acute therapy, becomes very tricky because you have to limit this to not more than 6 to 8 days a month. And where patients become very sophisticated, they say, okay, I'll take 6 days a month of this, and then the next 6 days I'll take this. Actually, it all counts. So it's all 6 days of total acute medication. So you can use 6 days of triptans and then 6 days of, let's say, anti-inflammatories and then 6 days of Excedrin. That's it, 6 days a month. That's your limit. So you have to decide what are the medications that are most effective for you. Usually we do combination of treatments in the headache clinic, such as triptans, Aleve, and Zofran. There are studies that show that adding Aleve to Imitrex, that was the medication called Trexamet, that was the most effective triptan. Unfortunately, a lot of the insurances did not cover it. So then insurances said, well, why don't you just add Aleve to Imitrex? I found that the over-the-counter Aleve, naproxen, blue capsules, along with Imitrex, along with Zofran, is usually a very effective combination for most of our patients. Now, if you give someone a triptan, does it mean they have migraine? So does a response to therapy predict the etiology of acute headache? Since I'm asking that question, you're wondering, well, why is she asking that? Because likely the answer is no. So if you give someone a triptan and they respond to therapy, does not mean that they have a migraine. You can use triptans for any headaches. All they do is they stop the final activation of trigeminal nerve. So this trigeminal nerve activation is seen in migraine, post-traumatic headaches, sinus headaches, and clusters. So just because you can stop a headache with a triptan does not mean that it's a migraine. Also, the triptan will stop the headache if the patient is having a stroke or dissection or any ominous secondary cause. So you need to actually, again, do the workup first. Not just give them a triptan in the ED and say, okay, they responded to triptan, therefore, it's migraine, I can let them go. Now, so what usually goes wrong? So what are the diagnostic and therapeutic pitfalls? When patients don't succeed, I have many patients, and we're having one of our neurology residents do a study to figure out how many patients actually had the adequate doses of preventive medication and had adequate preventive therapy. It turns out many people, if you do not give them the option of flexible dosing, they'll take one dose, they have side effects, and they say, forget it, I'm not taking this. So I have many patients who come to me, and within a year they've tried 20 medications, even though technically they should have not tried more than 1 or 2. That's one of the big issues. So what do I recommend? Do not try more than 1 medication every 3 months. If you're cycling too fast, you're going to go through your options very fast, and you're not going to succeed. It's very important to educate patients on the side effects, again, give them the option of flexible dosing. If you give excessive initial dose of medication that patient took only for a few days due to side effects, you're not going to succeed. So for most patients, duration of treatment is too short. So I see many of my colleagues, even who are neurologists and are really good neurologists, who cycle medications every month. It's way too short. It takes for prophylactic medication 3 to 6 months to be effective. Many people are non-compliant. Many people do not want medications. And we actually have our survey currently. I can tell you, out of the 1,000 patients we saw, more than 70% of patients prefer non-pharmacological treatments such as herbal therapies, biofeedback, diet changes. They don't want medications. So if a patient does not want a prophylactic medication, sometimes you can convince them that it could be a very useful bridge. Sometimes they just won't take it. So you have to have other options. Many patients have unrealistic expectations, as do we. And I've had patients over the years who come, let's say, start propranolol. I had one lady who said, doctor, it's just not working. And I said, well, let's look at your chart. So you used to have every single day headaches. Now you have 2 headache days per month, and you can easily treat them. She said, yeah, but I'm still having headaches. I said, well, the medication is actually super effective in you. With preventive medication, technically, if you look in the studies, you will decrease the headaches by about 30%. So if you're having more than 90% decrease in the headaches, you're successful. It will not get the headaches to 0. Our goal is to get patients from chronic headaches to less than 6 headache days per month and more tolerable if we can. Now, chronic migraine by far is the most common chronic headaches that we see. Again, what I told you, most chronic migraineurs will have both migraines and tension type headaches. However, what makes it worse is the unrecognized medication overuse. Most of my patients know that they should not be overusing medications, and they often don't report it to their doctors. They do not put it on the list. So we have to very, very delicately extract the history and say, okay, what are you using? Well, what have you used yesterday? How many pills did you take? And not be shocked when they tell you that they're using 60 Excedrin in a month or more, and support them. It's not their fault, but they want to get better. So how do we then approach refractory headaches? So key again is specific diagnosis. Whenever I don't succeed, I go back to the drawing board and try to see what am I missing. Deciding if it's secondary or primary headache, and medication overuse. We don't know the data, but it turns out that probably more than 80% of patients that we see have medication overuse, confounding any type of headache. It can convert any headache into chronic headache, especially migraine. What can we do then to treat them? Again, we've talked about the multimodal approach that includes lifestyle modification, decreasing their triggers, herbal therapy, getting adequate sleep. We have a sleep class. We also have excellent sleep providers at the University of Washington. Daily exercise, changing nutrition, decreasing stress, behavioral changes, physical therapy, massage therapy, acupuncture. We have a number of prophylactic medications that include beta blockers, antidepressants, anti-epileptics, and then we have acute medications that include the triptans, ergots, NSAIDs, and anti-nausea. So the goal of the headache evaluation, again, are twofold. Recognize a secondary headache that can be life-threatening, like meningitis or brain tumor. Recognize which primary headache syndrome are you treating, because then you can decide on specific treatments. So if a patient has cluster, you need oxygen and verapamil. If they have hemicrania, you need indomethacin. The distinction between primary and secondary headache is, again, especially important. Now, again, we recommend multimodal approach. You heard me during this presentation to say that at least 5 times. So, and we always tell patients that their participation in care is immensely important, and we're excited to work with them. Now, what are the supplements you can use for the patients? Magnesium. Magnesium has been studied, 400 milligrams 3 times a day. It's usually chelated magnesium. It can help also patients with constipation. Unfortunately, it can cause bowel cleansing and diarrhea, so the patients again have to use a flexible dosing to make sure they can tolerate that. B vitamins, especially B12, can be very effective, especially in your patients who have fatigue. Feverfew tea, we commonly use Feverfew tea. You can find it, it's in most compounding pharmacy in Seattle Pike Place Market, online. Amazon obviously carries it. Feverfew and lemongrass, patients can make it themselves. And the Feverfew tea can decrease headaches by up to 50%. So for many patients who are overusing Excedrin or Tylenol, I'll offer them Feverfew tea to drink at least 3 cups a day. And usually they like it very much because they're used to using something. So then they have something to use for the headaches that will not get them in trouble. SAMI is especially used, so this is S-adenosyl methionine. The dose is anywhere from 200 to 1600 milligrams a day. And this is in replacement of antidepressants. It boosts serotonin production. This is also something that I use for patients who have migraine-associated vertigo and depression and anxiety. Melatonin, so there are studies that show that melatonin significantly reduces headache frequency in patients with migraines compared to placebo. And it's about comparable to amitriptyline, much better tolerated than amitriptyline. The dose studies was 3 milligrams. You can use anywhere from 3 to 6 to 12 milligrams. Melatonin is also the key treatment in patients who have cluster headaches, or you can use it where you don't want to use indomethacin, such as indomethacin responsive hemicrania headaches. Melatonin is very difficult to absorb, so sometimes using liquid formulation of melatonin can be more effective. So what if your patients still continue to suffer from headaches? Well, we do have the headache clinic. However, there is backlog that we're trying to work on, but there is Botox that can prevent chronic migraine, SPG blocks, and we have shared visits for the SPG blocks. They can also be used to decrease headaches. We actually have data now for over 300 SPG blocks, and we'll share it with you later. Cephaly device. So if you Google Cephaly USA, patients do need prescription. It is a neuromodulation device. This device is safe and FDA approved. It can be used for any patient over 18, and especially for your pregnant patients or any patients who are super sensitive to medications. Now, it's not covered by insurances. It is about $350 plus another $25 for electrodes every 3 months. However, if patients use it at least 20 minutes a day, they can decrease their migraines by up to 70 to 80%. It's a very significant decrease in headaches. This is a very significant treatment, or kind of very optimal treatment option that can be used for the patients who are overusing Tylenol, Excedrin, Butalbital, and narcotics. Now, what is the future? So future, you'll hear a lot, and I have many patients who come to me and say, well, Natalia, all I want is the anti-CGRP antibody treatment. I've heard about it. It's supposed to be super effective. So on the slide, this is from Dr. Steven Stahl's book on chronic headache. You can see on the kind of bottom part of the slide, you have all the neurotransmitters that are released from trigeminal nerve during headache activation that includes CGRP, substance P, glutamate, and if you can suppress any of those, you can suppress headaches. And so the current newest treatments are working on anti-CGRP antibodies, and so far in the preliminary studies, these appear to be very effective. However, time will show. Here at the University of Washington, we're planning to do a study with anti-CGRP antibodies. There are many centers in the country who are doing these trials, and the treatment is usually given by sub-Q injection once a month to suppress the release of CGRP in the body. Now, on the top of the slide, you'll see that there are serotonin, norepinephrine, endorphins. So those are all the those are all the neurotransmitters that you want to increase to not have headaches. So this is kind of, I think, our last slide. And thank you very much. And I have Shelby coming up with questions that have been submitted. So I'm going to read those out, or Shelby wants to read them out to me. So, and I'll repeat them.
What's the best treatment for menstrual-related headaches, and any advice on contraception choices for these women?
So the question, there are actually two questions. So one was menstrually related headache. So the best for menstrually related headache is using combination treatments, not using only, so I'm going to go back to our acute treatments. So what you would want to use is a long-acting triptan, such as Relpax, along with Aleve, along with Zopran. Many patients will also add then azithromycin. I'm flipping through the slide. I apologize. So SAMI along, for this. Some women pre-treat with SSRIs or SNRIs just 3 days during the period and during the period as well. Now, the second part of the question was, what is the best birth control? So for many women, especially who have migraine with aura, they can have potentially increased risk of stroke with high-dose estrogen. So you want to avoid high-dose estrogen in patients with migraines, especially patients with migraine with aura. So using progesterone only, so like Mirena, IUDs, or using progesterone type treatments are considered much safer in patients with migraines. There are many physicians, many OBGYNs who will do continuous birth control for 3 months, and many women do find it effective if they have significant component of menstrual headaches. Now, I have many patients who will report that, quote unquote, they have menstrual headaches, and I'll say, how many days per month are you having the headaches? And they say 15. I can assure you 15 days per month is more than menstrual headache. Usually those patients have medication overuse, and if you address the medication overuse, they do much better along with prophylactic therapies. Okay, shall we next questions? So we don't have any other questions. So to kind of again wrap up, thank you so very much, for attention. So we were talking about chronic headaches. To sum up, the main questions that you're supposed to know how to answer were, I'm flipping through the beginning of the slides. And so again, what percent of people suffer from headaches? It's more than 90% of people. What headache is the most common? It's the tension type headache. What is the most commonly encountered headache by medical providers? It is migraine. How is chronic headache defined? More than 15 headache days per month. And what are common chronic, how commonly are chronic migraines seen? 13 to 30 million people in the USA. Again, the main point that I want to make sure that you know is that the medication overuse will make any headaches worse, especially migraine, but any other headache types as well. So thank you very much for your attention, and thank you for listening, and thank you for joining us. And I want to thank Shelby and Chelsea for organizing this. And thank you for listening. Have a nice day. Bye.